Hello, my name is Eric Secemsky. I'm an interventional cardiologist out of Boston, Massachusetts.
And I'm Eddie Choke, and I'm a vascular surgeon at Sengkang General Hospital in Singapore. And today we are here to talk about the role of sirolimus-coated balloons for peripheral arterial disease. So Dr. Secemsky, can I start by asking you this question? What do you see as the current challenges for the treatment of peripheral arterial disease?
Yeah, we continue to encounter many of the same issues we've discussed in years past. In my own practice as well as across the U.S., we still have very high amputation rates, and our patency rates for intervention continue to suffer in comparison, particularly to other vascular beds such as coronary artery intervention. So we know that we need to be able to provide a more long-standing and durable treatment for our patients and focus on really important outcomes, including reduction of amputation for those coming in with particularly advanced peripheral artery disease.
Right. So the arterial disease is becoming more difficult to treat, and they're leading to higher rates of intervention and higher rates of amputation. So what do you see as the potential role of paclitaxel-coated balloons or even stents for below-the-knee artery disease in peripheral arterial disease?
Yeah, one of the glaring deficits in our toolbox for treating patients endovascularly with peripheral artery disease, in particular chronic limb-threatening ischemia, is we are left with a few devices that are approved in the United States. Currently in the US, we have uncoated balloons, some vessel prep devices, and we use off-the-shelf, unimproved coronary stents when needed. So this field is ripe for us really developing the right technology to allow us to get appropriate endovascular flow to allow for healing of ulcers, wounds, and rest pain to reduce amputation. Again, we've seen the rest of the world really evolve in terms of their practice patterns, but not as much in the US. And I think that we've all been really excited about the potential for paclitaxel therapy below the knee, but we haven't necessarily seen the data demonstrating its support for how it can be incorporated in balloons and stents and be used to improve our outcomes for our patients.
Yeah. And what do you perceive as the role of stents for below-the-knee artery disease?
I think they're an important part of any procedural that involves balloon, crossing total occlusions. We know dissections need to be managed with scaffolds often, but we're also troubled by the fact that stents in both the above the knee and below the knee can fracture, can occlude, and can create bigger problems often. And so we really need a purpose-built scaffold if we're going to be using a scaffold for below the knee, or we really need to focus on the mentality of avoiding a scaffold and really focusing on drug-coated therapy that's delivered without leaving a metallic or bioabsorbable scaffold behind.
Right. So paclitaxel-coated balloons, they've not shown to be very effective for below-the-knee artery disease. And stents have its own limitations when used in BTK disease as well. So one of the other potential alternative is sirolimus. Now, I'm very interested in your opinion on this as a cardiologist. The cardiologists, I understand, have moved on from paclitaxel to sirolimus in the last 15 to 20 years. Could you give us a little bit more insight on how paclitaxel and sirolimus are perceived by the cardiology community?
Yeah, well, just to your original comment, we've been really frustrated that we've seen really important trials be very negative and even potentially harmful when using paclitaxel below the knee. We had a lot of promise on two device platforms in particular that failed to deliver. And so it's time really to step back and say, are we using the right therapy and the right approach to delivering that therapy? And so just as you mentioned in the cardiovascular world in the late 2000s and early 2010s, we saw this evolution of our first generation drug-coated stents that were paclitaxel-based to moving nearly completely to a limus-based approach. And really limus on these stents demonstrated superior efficacy as well as safety in the long term with very little harm for our patients. So all of our stents now in the US are drug-coated in the coronary space, and all of them have a limus-based platform. So we've gotten very comfortable with limus being an effective therapy for coronary intervention, and I use it in my daily practice as does my colleagues. So, on that note, I want to turn and ask you, we don't have a lot of experience with limus outside of the coronary, space. So tell me a little bit about how limus has made impact in your peripheral practice to date.
Yeah, so I'm a vascular surgeon, and my daily practice consists almost exclusively in dealing with CLTI patients for my peripheral practice. So we've been lucky to be one of the early adopters of the Magic Touch sirolimus-coated balloons. We've started using it since 2017, and we investigated its utility in a first-in-man trial called the EXOC trial, in which the 12 months results have been published 2 years ago. And basically, we found three things. Firstly, it was able to give us a very good 6 months primary patency of about 74% for BTK arteries. And for us, we were very excited about this 74% primary patency rate because we know from our previous trials we were only able to maintain it at 40% at 6 months using the conventional standard balloon. So 74% was a major improvement in our mind. Secondly, we found that we were able to achieve much less requirement for reinterventions. Our freedom from target lesion revascularization was about 87% at 6 months and 86% at 12 months. And we recently also looked at our 36 months data, and this is also maintained at about 84% freedom from TLR. And lastly, we were able to maintain very good limb salvage rates. Our 12-month limb salvage rate was about 92%. And at 36 months, this was maintained at about 84%. And this was in a cohort of very high risk, very hostile CLTI patients.
I think that's remarkable data. And if you think of what we consider the benchmark data and what we work off is, first we're thinking on the order of months, not years for patency, but also the ability to avoid another intervention or also an amputation in our patients is why we practice. So with that data in mind, tell me a little bit about your daily practice with limus-based therapies currently.
Yeah, so I use it mostly for BTK arteries and also for SFA arteries as well in our CLTI patients. And we've also looked at our real-world population data. So from our prospective registry of all our lower limb angioplasties in the last 4 years, we were able to look at about 140 patients who've received sirolimus-coated balloons. And we've compared this to patients who've received just conventional balloons. And we have found that in terms of our requirement for repeated interventions, we were able to reduce the requirement by a factor of 38%. Patients who received sirolimus-coated balloons were able to avoid these repeated reinterventions, which was very good. And also, we found that patients who received sirolimus-coated balloons had an absolute risk reduction of about 8% in terms of their amputation rates, from 96% at 12 months compared to conventional balloon of about 88%, although this did not reach statistical significance. So it has kind of impacted in a significant way our practice of lower limb angioplasties for our chronic limb-threatening ischemia patients.
That's wonderful. And just to end on that, any safety concerns that you've observed? There's been, with paclitaxel-based therapies, concern about delayed wound healing. Anything in your practice that you've seen as something you're monitoring or concerned by?
The short answer to that is no. So when we look at the survival in patients who receive sirolimus-coated balloons, at 12 months, the survival was 83%. So this is roughly in line with our very sick cohort of CLTI patients. And stretching out to 3 years, the overall survival was about 65%. So we're talking about really sick patient cohort here.
Yeah.
But obviously, these are just, first in man, small trials. We need to prove the efficacy and safety in randomized controlled trials in multiple countries, in multiple centers. So Concept Medical, I wish to congratulate them because they've got an exciting pipeline of clinical trials. So I'm the principal investigator for future BTK, which is looking at sirolimus-coated balloon versus conventional coated balloon in a randomized controlled trial. There's a similar trial ongoing in Germany at the moment called limus. And there's also another trial in Switzerland, which is looking at sirolimus-coated balloon strategy versus conventional balloon. And there is also a head-to-head trial looking at sirolimus-coated balloons versus paclitaxel-coated balloons for BTK being run in Italy. So we expect to see loads and loads of data coming out in the next few years.
Well, I agree, and I think Concept Medical will be launching similar trials in the U.S., which I'll be serving leadership on, and we'll be excited really to have the opportunity to bring this therapy to the U.S. for our patients. So I really thank you for that wonderful insight, and again, I want to thank everyone for tuning in. There's a lot to come over the coming months and years, as Dr. Choke laid out, and I think we have the opportunity really to make a difference for our patients, and appreciate you tuning in.